It's my pleasure to speak today. I'm going to talk about positive airway pressure therapy for obstructive sleep apnea. I'd like to thank the organizers for having me here today, and it's a pleasure to share the podium with such distinguished speakers. By way of disclosure, the National Institutes of Health fund my laboratory. I've received some personal income from Merck and from LivaNova for some work I do related to medical education. I'm a member of the MedX Cloud, which is an academic industry partnership funded by ResMed, and ResMed has provided a philanthropic donation to the University of California, San Diego, but I've received no personal income from either MedX Cloud or from ResMed. So I'd like to start by talking about this study. This is the SAVE study published in the New England Journal of Medicine back in 2016 by Doug McAvoy. In my view, it was a good study, and it showed really no benefit to CPAP treatment for the prevention of cardiovascular disease and obstructive sleep apnea. Therapy with CPAP plus usual care, as compared with usual care alone, did not prevent cardiovascular events in patients with moderate to severe sleep apnea. And there are a variety of reasons for this finding, but in my view, there's sort of three take-home messages. Number one is we probably need better therapies and better adherence to existing therapies, because even though they reached the targets that they were looking for, as far as positive airway pressure was concerned, in fact, it probably still wasn't adequate for cardiovascular benefit. I think we also need to identify high-risk patients better. Giving CPAP to everybody doesn't seem to work, at least from the standpoint of cardiovascular disease prevention. And we need more basic research regarding underlying mechanisms. So the outline is talking, I'm going to give a little bit of background. We'll talk a little bit about positive airway pressure adherence currently. We'll talk about some rescue strategies and then some future therapies. So this is a paper we published in the Lancet Respiratory Medicine about a year ago now, estimating the global prevalence of obstructive sleep apnea based on existing data. The data aren't perfect because we only have data from a handful of countries, but our best estimate was almost 1 billion people affected worldwide if you consider an apnea-hypopnea index greater than 5 events per hour to be clinically important. If you raise the bar higher and say 15 events per hour, that is a breathing problem once every 4 minutes, which most of us would agree requires therapy, it's almost 500 million people affected worldwide. So whatever strategy we come up with in terms of diagnosis and treatment will have to be scalable. The idea that everybody's going to get a polysomnogram and an in-laboratory titration just does not seem feasible. If you look at the top 10 countries that are represented here as far as the prevalence of sleep apnea is concerned. So the take-home message so far is that sleep apnea affects up to 1 billion people worldwide. The scoring criteria seem to matter a lot. What you call a hypopnea can make the numbers change considerably. We need to think about how to address this global burden. Now you might say, who cares? What difference does it make if there's people out there in the community who have disease and they never come to clinical fruition? Maybe just leave them alone. It was a paper we published with Raphael Heinzer, the Hypnolos cohort, also in the Lancet Respiratory Medicine about 5 years ago. It was a community-based sample. They went into the community, did polysomnograms on people, and saw what happened. And the numbers were quite striking. Moderate to severe sleep disorder breathing, based on an AHI greater than 15 events per hour, was seen in 23% of women and 50% of men, really quite high numbers. And in multivariate analyses, the apnea-hypopnea index was predictive of hypertension, diabetes, and depression, suggesting that asymptomatic disease in the community may still have consequences. So the concept here is that sleep apnea is highly prevalent, but not all these patients are likely to develop cardiovascular benefit from CPAP. That is, I'd be very surprised if 50% of men in Switzerland get cardiovascular benefit from CPAP when they're not all at cardiovascular risk. And so we need to get better, as I mentioned, about stratifying who's at high risk and who is not. If you look at long-term use of CPAP therapy, this is from Nigel McCardle and Neil Douglas in Edinburgh, Scotland. The predictors included the apnea-hypopnea index, the severity of sleep apnea, the Epworth Sleepiness Score, the degree of symptoms, and snoring. And this was published in the Blue Journal now more than 20 years ago. But I think the findings still hold that the more severe disease tends to use CPAP in the long term. There's also questions about intensive support. Can intensive support improve CPAP therapy? The data here are somewhat mixed, but I go back again to Neil Douglas 20 years ago, who showed that intensive support could improve CPAP adherence at 1 month, 3 months, and 6 months, suggesting benefits to education and support for these patients. So this is a study that was published by Geraldo Lorenzi Filho from Sao Paulo, Brazil, looking at nasal versus oronasal CPAP for obstructive sleep apnea treatment. It's a forest plot. To the left of the zero line is the CPAP level, and you can see the CPAP levels are somewhat less people using nasal CPAP as compared to oronasal CPAP. In that same context, when they look at the efficacy, oral nasal masks are associated with higher CPAP levels as compared to nasal masks, higher residual apnea-hypopnea index, and poorer adherence to therapy. But one thing I'll say to emphasize is that a patient that chooses an oral nasal mask is very different from one who's randomized to an oral nasal mask. So I have plenty of patients who prefer the oral nasal mask, and so again, speaking to the need for individualized therapy. So take-home message so far regarding CPAP. Sleep apnea is a highly prevalent and serious problem. Long-term adherence is not that bad when compared to other chronic medical therapies. If you compare CPAP use to inhaler use in asthma or anticonvulsant use in epilepsy, it looks kind of favorable. Intensive support may be helpful, as I showed you, and optimizing the mask and decongestants and these other things should be individualized. Not everybody does well with humidification, but some patients prefer it. Not everybody does well with an oral nasal mask, and an aggregate nasal may be better. So let's talk about positive airway pressure adherence currently. This is from a big data analysis that we published in CHEST about 2 years ago now. This is looking at patient engagement using nasal or new technology to improve PAP adherence, a retrospective analysis. This is derived from almost 1 million patients on the cloud from 137 million nights of data. On the y-axis here is the cumulative percent of patients, and the x-axis is time. And this is time to reach Medicare criteria. The Center for Medicare Services has criteria in terms of what they consider optimal CPAP use or adequate CPAP use. You can see the blue line is usual care. About 70% of patients develop Medicare adherence based on usual care. But if you're in the red line, that is patients who are getting modern technology with patient engagement software, it's up to 87% of patients getting CPAP adherence. 87% of patients getting Medicare criteria using modern technology with patient engagement. And so they get a thumbs up if they're doing well, they get helpful hints if they're doing poorly. And that type of technology is getting up to 87% adherence. Now, by and large, this is representative of most of the patients that I see, but you have to be on the cloud to get into this particular study. So if you couldn't afford to get a sleep study or you didn't have the inclination to get a CPAP machine, then you wouldn't be included here. You have to have at least 1 hour of CPAP use in total to be included in this analysis. And so in areas of the world where CPAP is not available or sleep testing is not available, these data don't pertain. But for most of the patients I see, at least 1 hour of CPAP use in total, 70% getting usual care have Medicare adherence criteria and 87% using modern technology, which is really quite good. And here's a different way of looking at the same data. On the left is active patient engagement. On the right is usual care. The blue colors are good adherence. The red colors are poor adherence. And you can see active patient engagement overrepresents the patients getting 7 hours or more of CPAP use per night as compared to usual care. But still, both are doing quite well. And then if you look at Medicare adherence, as I mentioned, 87% adherence using modern technology, 70% using usual care. So if that sample size wasn't enough for you, you can see that Peter Sestouli did this analysis as part of Medic's Cloud as well, looking at short-term CPAP adherence and obstructive sleep apnea big data analysis using real-world data. And here we're looking at 2.6 million patients in the column there on the table, and CMS compliance in the first 9 days seen in about 75% of patients with all comers. And again, you need at least 1 hour of CPAP use to get into this study, so it doesn't pertain to everybody. But 75% adherence in a massive sample size like that is really, to me, quite reassuring that CPAP is not so bad. I think a defeatist attitude about CPAP is really not justified. And just zoomed in there, 2.6 million patients, about 75% meeting Medicare criteria. So let's talk a little bit about rescue strategies. This is looking at bilevel therapy as a rescue strategy, and this is again from Medic's Cloud. It was published in the British Medical Journal Open Respiratory Research back in 2019. U.S. insurance reimbursement pathway: within the first 90 days of CPAP, you can switch from bilevel for pressure intolerance to help achieve Medicare adherence. You can switch up to day 60 and have to the original 90 days to show adherence. The switch between day 61 and day 90, you have up to 120 days to show adherence. Study overview here is we took U.S. AirView patients on the cloud, switching from CPAP to the bilevel mode within the first 90 days, and the primary outcome was once again CPAP adherence. And if you could look at the days of switch here, 25th percentile, the median is 54, 75th percentile is 71, and the mean is 51. So on the x-axis here is days from start of CPAP, and the y-axis is patients being switched. You can see that the day of the switch varies between the time shown there, so it tends to go up over time. If you look at the impact of the switch, patients who switched from CPAP to bilevel within 90 days is about 1,500 patients here. You can see by and large the patients do well. The auto or fixed CPAP is more likely to switch to auto or fixed bilevel. And if you look at the average apnea-hypopnea index and the leak, they look slightly better after the switch. If you look at the percent of patients compliant based on Medicare criteria, also improving considerably after the switch. The median goes from 52.7 to 68.9. Average hours of use also go from 3.85 to 4.75. So the overall adherence with bilevel based on Medicare adherence or compliance is 57%, which really isn't so bad for patients who are struggling. And if you look at leak, it also looks somewhat favorable, though the numbers are statistically significant. It's debatable whether they're clinically significant. But suffice it to say, I was reassured that the adherence looks better and the other things are going in the right direction. And if you look at usage improvement in terms of days switched, patients switched earlier seem to get the greatest improvements, although again, the differences are quite small over time. And then compliance improvement by day of switch. This is number of patients, days 0 to 60 and 61 to 90. You can see that there's a slight improvement with the earlier switch as compared to the later switch, but I don't make too much of that, and it's not even statistically significant. We've also done some work in pediatrics here. This is starting with 30,000 patients to look at impact of adherence, and this is in press now or recently published in the Lancet Digital Health. If you look at the age distribution here, there's some patients at age 0, those are probably misclassified, but if you look at between ages 5 and 18, you can see quite a number of patients there. On the right graph, you can see the distribution of ages in terms of number of patients based on age group. And we use Medicare adherence here. Medicare is generally not used for children, but that was the best we could do as far as adherence criteria were concerned. You can see in the age group of 9 to 12, the compliance was highest at 53%. In the age group 15 to 18, the adolescents or teenagers, it was 37%. It was somewhat lower. I will also point out that active patient engagement was also quite helpful in the pediatric group, suggesting potential benefits there. But by and large, I was actually surprised that Medicare adherence wasn't so bad in kids. My kids don't listen to anything I say, and so I was surprised that this many kids and their parents were able to achieve good adherence. I'd also like to talk about the switch to ASV. So sometimes patients are on CPAP and they're switched to one of these newer modes for central apnea. Again, from MEDEX Cloud, Jean-Louis Pepin is the first author on this. It's derived from almost 250,000 patients, looking at patients switching from CPAP to ASV. The big data approaches here support switching to ASV in patients on CPAP who have a residual apnea-hypopnea index. I'll show you some data here. This is from the same study on the left, where trajectories of average positive airway pressure usage before versus after the switch. You can see the day 0 is where the switch was defined, and when they went to ASV, the average PAP usage went up abruptly at the day of the switch. If you look on the right graph, figure 3, the average apnea-hypopnea index also improves abruptly on the day of the switch. And so it's somewhat gratifying for me to see that the switch to ASV is leading to improvements in adherence and reductions in residual apnea-hypopnea index. So bottom line here is big data approaches support the use of ASV in CPAP-treated patients with residual apnea-hypopnea index. Let's talk a little bit about future therapies. So some of you have heard me before say the underlying mechanisms or endotypes are variable in sleep apnea. Patients don't all get sleep apnea for the same reason. There are anatomical factors, there's pharyngeal dilator muscle control, there's the arousal threshold, that is a propensity to wake up, so-called loop gain, which is a measure of the instability in the ventilatory control system, A high loop gain is a group that's prone to instability, whereas a low loop gain is one that's intrinsically stable. There's other factors such as lung volume and vascular factors as well. So why do these endotypes matter? It's a busy slide and I won't go through it in too much detail, but we'll just go through the 4 bullets here. Why do these OSA endotypes or mechanisms matter? The endotypes may guide therapeutic interventions. We know oxygen or acetazolamide may be quite helpful if there's unstable ventilatory control or a high loop gain. Uvulopalatopharyngoplasty may be quite helpful for patients who have velopharyngeal compromise. That is anatomical factors at the level of the velopharynx. Risk factors for sleep apnea may be related to endotype. So we know in post-traumatic stress disorder, the arousal threshold may be one issue. Upper airway dilator muscle dysfunction may be an issue in neuromuscular disease. Sleep apnea endotypes may predict clinical phenotypes. We know sleep apnea in the elderly may have a low loop gain and minimal esophageal pressure at arousal. So that may explain why there are fewer complications in sleep apnea in the elderly as compared to younger individuals. The mechanism underlying disease may be different in different age groups. And then sleep apnea endotypes may predict treatment response. We know high loop gain patients may develop central apnea when you put them on CPAP. We know the low arousal threshold may develop insomnia when you put them on a positive airway pressure, as Andrei Zinchuk and others have shown. And then a high loop gain may predict surgical failure. We and others have shown that upper airway surgery doesn't do much to ventilatory control, so it's a pretty good predictor of failure of upper airway surgery. There are also different phenotypes of sleep apnea, that is, the clinical expression of disease may be quite different. Endotypes are mechanisms underlying disease, phenotypes are clinical expression of disease. And we know the different clinical phases of obstructive sleep apnea is a cluster analysis by Li Xuan Yi, although corroborated by Alan Pack and the broader group doing analyses in the Sleep Art Health study. And it falls into different categories, these clusters. Some have disturbed sleep, some are minimally symptomatic or asymptomatic, and some have severe sleepiness. The severe sleepiness appear to be the subgroup that's at highest cardiovascular risk. And again, putting everybody, all comers, into randomized trials may not show benefits because not everybody's at risk. Why do these things matter? Well, it may be individual susceptibility, as I mentioned. There may be early versus late stage disease. Perhaps people move from one cluster to another over time. And there may be different underlying mechanisms as well. Perhaps asymptomatic sleep apnea has different mechanisms from severe sleepiness sleep apnea. And these are some data we published a few years ago from Mike Stankina in Rhode Island and Scotty Sands as a co-author, where we looked at patients who develop complex sleep apnea, that is treatment-emergent central apnea that persists on CPAP therapy. And our estimate of loop gain here, which is a measure of instability in ventilatory control, was a function of the residual apnea-hypopnea index, suggesting control of breathing abnormalities were what was driving the residual apnea being observed. And then the point I made earlier about surgical outcomes, you can see that physiology-based modeling may predict surgical treatment outcomes for obstructive sleep apnea. Sylvia Lee, who's an ENT from China, who spent some time with us in San Diego, and Bob Owens, my colleague in San Diego, were the main authors on this. And the bottom line here is that high loop gain predicts surgical failure if you're getting uvulopalatopharyngoplasty. Loop gain lowers after surgery, suggesting that the abnormality may be at least partially acquired. And low arousal threshold also predicts surgical failure. That may be a therapeutic target because you have drugs such as sedative hypnotics that can raise the arousal threshold if that's the culprit underlying surgical failure. So by way of summary, this is published in The Lancet a few years ago now. At the bottom, you can see CPAP is a treatment for obstructive sleep apnea, and that works well in people who tolerate it. For people that don't, there are a variety of other possible treatments listed there, including surfactant or mandibular advancement devices or oxygen or acetazolamide, hypoglossal nerve stimulation. And really, those should be targeted based on the underlying mechanisms that are shown in green. If the problem is poor upper airway muscle function, perhaps hypoglossal nerve stimulation is the way to go. If the problem is respiratory instability or high loop gain, perhaps oxygen or acetazolamide is the way to go. If there's a low arousal threshold, as shown on the right, perhaps sedative hypnotics may be the way to go. And this slide, although complex, is probably an oversimplification because many people have multiple underlying mechanisms, and perhaps combinations of therapies are required really to eliminate sleep apnea. So I'll summarize by saying nasal CPAP is the treatment of choice for obstructive sleep apnea. It's well tolerated in general. Again, 70% adherence with usual care, 87% adherence with modern technology is nothing to sneeze at. Supportive efforts and rescue strategies can be effective for people struggling with CPAP. I showed you data on bilevel rescue or ASV rescue that seem to be effective. Big data approaches are informative but do not replace randomized trials, and so I think some of these are hypothesis generating, but some of them are clinically directive, at least until we have more definitive randomized trials. And they'll say the future may require improved mechanistic understanding to individualize therapy. These mechanisms underlying sleep apnea and the phenotypes whereby different sleep apnea patients come to clinical fruition differ. A one-size-fits-all strategy for obstructive sleep apnea may not work because the mechanisms are different, the clinical expression is different, and everybody's different. So I'll stop there. I'd like to thank you all for attention, and I'd like to thank the organizers once again for having me here today. Thank you.